Okay, we're still gathering. We'll give it just a minute and begin. Okay. Hi, everyone. We're very excited to have you here today joining our virtual panel event. And we'll spend the next hour exploring how technology can help to mitigate health disparities. I'm Jen Sato. I'm a board member of Health Tech Build. And before we start, I did want to take a minute to talk about what Health Tech Build is about. We're a mission-driven nonprofit, and we're focused on accelerating digital technology in life sciences and healthcare. We host many events virtually and hopefully again in person. We've been very fortunate to have many leading organizations participate. If you'd like to learn more, go to our website, healthtechbuild.com. We're always looking for new sponsors. This is how we make these events happen. And if you're interested, please reach out to us via the website. We have a great panel here today, and I wanted to thank the speakers, as well as Medicuity, our sponsor. And in particular, I wanted to thank Tom Busby, a fellow Health Tech Build board member who will be moderating. If you have any questions, please use the chat function. We'll take as many of them as we can. And with that, I will go ahead and hand it over to Tom.
Thanks, Jen, and hello, everyone. It's a pleasure to be here today to welcome you all to this fantastic panel event. With me, I'd like to introduce Mark Friedberg, Senior Vice President of Performance Measurement and Improvement at Blue Cross Blue Shield, Lucienne Ide, Founder and CEO of Remedy and Co-Chair of the HEAL Coalition, and Leon Boston is joining us today from Israel. He is the CEO, Chief Executive Officer of Women's Health and Artificial Intelligence company, Mobile ODT. I'm excited as well myself to join everyone today, both as a board member of Health Tech Build and a vice president at Outcome Capital. We are a technology, life sciences, and healthcare investment banking advisory group, and excited for today's discussion. So I think that we can begin perhaps by setting the table on talking about specifically what disparities do we see in each of our roles in the healthcare system. Lucienne, I was hoping maybe that you could kick us off here. So what particular and key disparities do you see via treatment, prevention, access, education, and thinking really both domestically and abroad? What do you see from your vantage point?
Thanks, Tom, and thank you everybody for joining today. So as Tom said, I'm founder and CEO of Remedy. We're a digital health company focused on quality improvement, workflow optimization, and patient engagement work, mostly around chronic disease management, which leads into a lot of conversations around these access, education, and treatment disparities. In addition, I'm co-chair of something called the Health Equity and Access Leadership Coalition, so HEAL. And that's a joint effort of the Consumer Technology Association and the Connected Health Initiative. And I mentioned that because that was really an ongoing dialogue in the tech community around disparities that was then accelerated due to COVID and the conversation that many of us have been having over the past year plus. And so those disparities that we were seeing, geographic disparities, both urban and rural, right? And they may take different forms in those different geographies. Urban communities often have, huge life expectancy gaps in neighborhoods. So I'm based in Atlanta, Georgia. And, between poor parts of Atlanta and wealthy parts of Atlanta, we have about a 14-year life expectancy gap, depending which zip code you live in. But rural communities have their own challenges, right? They over-index on chronic health conditions, diabetes, obesity, et cetera. And then they have generally more challenges around access to care. And then, I think the third category that I really want to mention is sort of race, ethnicity, and gender, right? And the disparities that happen on those lines. So again, to take data from my own state in Georgia, we are 50th in the country, in a bad way, on maternal morbidity. And so, and it stratifies across racial lines. So if you're a Black woman in Georgia, you're as likely to die in childbirth as if you were having a baby in Iran. And, something needs to be done about that. And, I'm sure the panel will dig into those issues of what's underlying that and how can technology help.
Thanks, Lucianne. That's appreciated. Perhaps Leon or Mark, maybe if you could elaborate, from your perspectives too, what disparities do you see?
So, I'll go. So my name is Leon Boston. I'm the CEO of Mobile ODT. We are a femtech company. We're in the world of artificial intelligence, specifically in the world of cervical cancer. We sell in about 20 different countries around the world. And one of the things that we do see disparity in regions. But the disparity, sometimes there's less disparity. The further away you go from the first world, there's less disparity. And I'll explain this paradox. This paradox comes from there's less racism in a specific territory because everyone is the same race. There's less inequality because everyone is has the same level of wealth in that thing. What we do find is not a disparity based on race. There's a disparity based on the accessibility. The people do not have, some people are further away from a medical care, and accessibility is something that creates disparity. And one of the things that we do in our technology is give accessibility by using AI, artificial intelligence, and I'm sure we'll touch on this as we go along. By using artificial intelligence, you circumvent the necessity for a specialist, and that gives accessibility. So accessibility is a type of disparity, not based on race, but based on the distance you are away from getting healthcare.
And I'll go next. So Mark Friedberg, I'm here in Boston, Massachusetts, at Blue Cross Blue Shield of Massachusetts, and general internist. And in my role, I'm the Senior Vice President for Performance Measurement and Improvement. So one thing we look at from the payer perspective, and this is common among healthcare providers also in the United States, is inequities by patient race and ethnicity in the quality and content and service level of care received. This ends up being a longstanding and persistent problem with the United States healthcare system. And our role is to, at least initially, do what we're calling equity audits. So spend a fair amount of time and resources internally trying to quantify the amount of inequity that we're able to observe among our members. And that's as a first step towards being accountable for improving on the equity of care that our members receive over time. We recognize this is going to be a long-term effort, and we're not going to be able to do it alone. And we have to work very closely with our provider network and many others inside and outside the healthcare sector to produce what our ultimate goal is, which is equity on healthcare quality and health outcomes.
Thanks, Mark. And maybe we can, push the subject a little bit more, especially from your vantage point. If we sort of unpack the traditional healthcare stakeholders of payer, patient, and provider, who do you see as being early adopters of technologies really to, mitigate these disparities? And then conversely, who do you see as the laggards who are really sort of preventing and maybe even perpetuating these disparities down the line?
Yeah, it's a great question. I guess the way I'll say is I don't think there are sector by sector or actor by actor generalizations I can make. So it would be not correct to say that the payers are behind or the providers are behind or some other group of stakeholders is behind. I think there's way more heterogeneity in terms of ability to act within a category than there is between categories. So just to give you a sense of where many health plans start, Blue Cross of Massachusetts among them, we don't have a whole lot of gold standard race and ethnicity data for our members. And by gold standard, I mean how our members self-identify their race and ethnicity. We have less than 5% total of members with gold standard observations. And that's very common for payers throughout the country. Some are a little higher on that figure, but nobody's anywhere near 100%. Providers are in a similar place. Depending on the provider, they might have more or less than that amount of data. and they may have less or greater amount of accuracy, or rather a sense of how accurate the data are. So it's one thing to have an observation in a database that says, patient XYZ self-identifies or is race, let's say Black race or Hispanic ethnicity or Asian race, or any number of other categories that you have to have in order to even measure the inequity in the first place. The accuracy of those observations is often unknown. We don't know how the data got in there. There's no industry standard provenance codes, meaning we don't know when they were entered sometimes. We don't know the data standard on which they were entered. We don't know the method by which the data were collected. Is it a survey a patient filled out with known characteristics, or is it observed? Maybe a healthcare provider made their best estimate, and that's what got in there. And those are indistinguishable in most, if not all, databases that we've encountered. So there's a lot of, I would say, capacity building, data storage, data handling, data governance, and analytic work that needs to happen. And I think as an industry, we're starting to take this much more seriously than we did more than a year ago. And we're moving in the right direction, but this is going to take some time.
And so maybe, Lucienne, we can move over to you, and in your experience as well, do you think that we have appropriate incentives for payers, patients, and providers to want to address these disparities? Is there enough awareness? And are we actually instigating that change by putting a carrot in front of the stick?
Yeah, I think it's an interesting question about patients, right? Because I would sort of remind us all that patients are people, and I would argue that we all fundamentally value our health, right? For different reasons, but many times for medically underserved communities and lower socioeconomic communities, their health is that much more important because they don't have a safety net, right? If their health isn't well managed, they can't go to that job that they require, paycheck to paycheck, where they live paycheck to paycheck. So in work that we've done in those communities, I always come back to the access and education questions. And Leon mentioned the question of access, but I think education is sort of the fundamental underlying issue there as well, right? If we offer the correct education of why this matters, this particular chronic health condition, for example, diabetes or hypertension, and then we offer the access, I would offer we don't have any laggards there who wouldn't, take us up on that. But it's a question of, are we doing so in a culturally appropriate way? Are we doing so in a mechanism that builds trust in that community? And I think, we've all seen a lot of lessons around this in the past year with COVID testing, COVID treatments, and then COVID vaccination, and some really good examples of where those things are done well, right? Simple things like not requiring an appointment for a vaccination that automatically sort of worked against certain parts of our society who don't have access to a computer or smartphone to schedule that appointment, but we allow for walk-in vaccinations. We saw a huge bump in access to vaccination for certain communities. So on the patient side, that's sort of my answer. I think on the provider side, right, your question of the carrot and the stick and how do we incentivize providers? As a clinician myself, we all go into this to do good and to help patients. But unfortunately, in the day-to-day practice, other mechanisms, reimbursement and other things do get in the way of that. So I totally agree that we need to provide the appropriate, hopefully carrots, but probably sometimes sticks to really address this. But it comes back to Mark's comment, if we can't measure it, then we can't, implement these programs to enforce it.
So maybe actually, Lucienne, if I could push you here a little bit, one step further, it sounds like you could even make a case that paradoxically, technology is amplifying disparities. So you bring up telehealth, for instance. So a person needs to have strong broadband, they need to have the technology to be able to do it, and they need to have the awareness of, this is an avenue for me to receive care. Are you seeing, that paradox actually coming to light? Or are these technologies actually, especially telehealth, are people actually using that, and where do we stand?
So these are a lot of the recommendations that the HEAL Coalition is working on to the current administration of how do we ensure that we don't worsen disparities through technology or perpetuate disparities. Broadband, right, great example. There's a lot of good work at the federal and state levels around broadband access. But telehealth is an interesting one. So there's currently legislation and work going on around sort of permanent changes to telehealth reimbursement. There were a lot of changes under the public health emergency, but making those permanent. And one is originating site. and the requirement that a patient to qualify for telehealth, that the originating site could be their home. But if you think about that, does that discriminate against individuals who don't have a home or who don't have broadband access in their home? And so imagine you can't access a telehealth appointment if you can't do it from your home, and in your home, you don't have internet access. And so, there's really good work by folks in the community to help educate and ensure that we don't legislate disparities into our US healthcare system.
Tom, I just want to add on to what Lucine just said, and I want to look at another extreme case of disparity in the US market, but I have to just say this, I have to talk about, I'm just going to put up one disclaimer out there. I'm not American, I'm Israeli, but the extreme case of disparity in the US healthcare system is that 31 million people are uninsured in the healthcare system. That is an extreme case. You talk about telehealth and you don't have access to telehealth, and I accept everything you say, but the Affordable Care Act reduced that to a certain amount from about 45 million people. This is an extreme act, and I'm not sure that the stakeholders are really interested in a remedy for this extreme group of people. And why? Because they're disenfranchised and they have very little political clout. And I think this is what you need to be talking about. You can talk about disparities in the African-American community and everything like that, but there's an extreme case in the United States. In Israel, for us, it seems it's an eye-opener because we have a healthcare system which is a healthcare for all, and we don't have uninsured people. But these group of disenfranchised people is the extreme case of disparity. And the shareholders and the stakeholders, I am not convinced that they want to find a remedy for this issue.
Leon, maybe we can stay on you for a moment here. I think you're in an interesting position here, given that your company is trying to really change the standard of care when it comes to cervical care screening, and like you said, leverage AI to really be able to democratize better colposcopy exams. So I guess my question to you would be, as someone who's trying to commercialize the technology worldwide, to kind of close the gap, you have another framework that you have to be aware of, which is the regulatory environment. And we know that the FDA has shown a little bit more openness to AI assets, especially with screening. But as a chief executive officer of a company really targeting these disparities, what stakeholders have been the greatest challenge for you to win over?
So as you mentioned, the FDA is really very much open to artificial intelligence. They realize that artificial intelligence has a huge benefit for different disenfranchised populations and for helping to close that gap. And how does it close the gap? In our case, if we talk about the United States, people people do not have access to a colposcopist, the artificial intelligence overcomes or circumvents the necessity to have a specialist in the room. Because if we have an algorithm that is as good, as gives a result as good as a specialist in the room, that allows us to place our technology in rural areas, in areas where there's no access to colposcopists, and get a result as if you were standing in a colposcopist office in Manhattan. This is a huge advantage, and that's why the FDA is very much open to looking at technologies which would make a major impact on disparities in the United States. And I do think they really want to make a change. So these type of technologies will make an impact.
So I think we're lucky to have two clinicians with us today, Mark and Lucienne. And if we were to sort of use you as proxies for the clinical community, I know when we have young companies raising venture capital, for instance, one of the questions that investors ask is, are physicians on board? Do they really want to adopt this technology, and are they excited? Do they agree that the problem that you've identified is a problem that they, also see in day-to-day work? So speaking on, if you put your clinical hats on, do you think that clinicians agree that there's disparities out there, we need new technology to close the gap, or are they concerned with a million other things that they've always been inundated?
I think you're not going to find too many clinicians that don't think there are tremendous inequities in the quality and outcomes of healthcare in the United States. for many, many reasons. I think to Lucine's point about incentives, I don't view financial incentives necessarily, especially when they're linked explicitly to equity, as being necessary to motivate clinicians to close inequities. I think people, almost to a person within the healthcare provider community, are inherently motivated to close inequities in care. What incentives do create is a business case for a larger organization to make investments that cost money to reduce inequities in care, a more direct business case than already exists. So that's where I think the incentives can really play an important role, especially when they're explicitly linked to the equity of care. Now, the role of technology in all this, back to your, answering your main question about when can new technologies be useful for improving the equity of care, I think it's going to depend on the specifics of the case. Within Blue Cross of Massachusetts, we've adopted an internal framework that we're trying to use to guide our strategies around equity of care. So its first step is seeing. That's the equity audits I mentioned, where we want to measure where we are right now. The second is understanding, and this is critical. So I think for some inequities, a technological solution might be a very good fit, potentially, especially for the example of, you don't have colposcopy access in a certain area. Maybe a technology can really be a solution, and you should play that out, draw out the logic model for the clinicians. I think if you're able to do that, and especially then link it to an incentive that a payer's put in place or that someone else has put in place, then I think you've made a pretty powerful business case to the provider organization. That might not be the case for every inequity. Some inequities may not really lend themselves to a technological solution, so it's going to depend on the particularities. And I want to be really clear here that we don't want to have paralysis by analysis, where we're stuck in that understand stage. We're getting perfect data before we choose to act. I don't think that's productive either. I think you want to have enough of a sense that you have a reasonable likelihood that something's plausibly going to have a good effect, and then evaluate it for its effectiveness.
Yeah, I would wholeheartedly agree with Mark, and I think all of us have those experiences of, going, spending the extra time, going the extra mile, walking the patient to the pharmacist, doing taking those extra steps for that patient who or you're worried about, right, isn't going to get the follow through, isn't going to be able to access their medicine, whatever that next step in care is. And one thing that brings up, I think, is it's not the motivation, the altruistic motivation, if I want to do the right thing by every single patient. It's the time constraints that really often get in the way of that, right? There's the reality that you have 40 patients on your clinic schedule that day, or you have an ER full of patients waiting to be seen. And so I think that's where technology, I often, encourage folks to think about that, of like, what's the efficiency gain by this for a clinician, for a patient, for an administrator, for a front desk person? Because sometimes better isn't good enough. It has to be, better and faster. And to me, the time is more precious than money in many healthcare settings. So that's where I think engaging with clinical teams, engaging with, administrators over service lines, nurses, pharmacists, anyone, I encourage technology companies to do that, to really understand sort of that process map and what does your workflow look like and how would you use this and what process am I replacing today? Because if you can't really understand all of those design elements of how somebody would leverage the technology, not just to deliver a better outcome for that patient or a better experience, but to leverage fewer resources or take time off of somebody's day, it can be really hard to drive the adoption.
Great. I want to turn our attention now, because we've kind of been circling the topic of what particular technologies are we getting excited about, and what technologies are really now being leveraged to bridge the gap, and in the future, where do we see that sort of playing out? Leon, maybe you can kick us off. I know that you've talked a bit about artificial intelligence. Maybe you can elaborate a little bit on how AI is really starting to bridge that gap with these disparities.
So as I said to you, we sell around the world, and there's disparities all around the world. So if I look at a developing country, whereby we introduce artificial intelligence into a developing country, where we've taken our algorithm is based on input that we got from top colposcopists trained in the United States. And once we've taught our algorithm how to recognize an image of a cervix, it's as if we've taken that level of accuracy that we find from top colposcopists in the United States and bring it down into the most underdeveloped countries in the world, and that reduces the level of disparity between healthcare, between screening programs in the United States and in a developed country, because the accuracy that artificial intelligence brings, if it's a good artificial intelligence, is something that you will not find in a developing country because of the training, because of the nature of things. And then when you look at a first world country like the United States, there is a lot of disparity in access to colposcopy. So we overcome these issues by artificial intelligence. Artificial intelligence overcomes the issues of accessibility, overcomes the issues of having a physician in-house at the time at point of care. So this is what I see artificial intelligence making a major impact on disparity around the world.
Maybe we can open up. Lucienne, Mark, thoughts on AI? I know, Lucienne, you brought up telehealth, and maybe we can expand the question too. What technologies near term are getting you excited? And as we look maybe longer term, 3+ years, what technology do you see coming online that gets you excited here?
Sure, I'll jump in. Thanks. I'm actually doing another panel later today about AI and sepsis. And so I think, the near term, I think AI for screening purposes is, there was the approval of, sort of retinal screening. I think colposcopy makes a whole lot of sense. I trained in OBGYN, so near and dear to my heart. And there is some angst around that, and I think we need to get the clinician community on board. And I've heard people want to refer to it as augmented intelligence that makes them feel a little bit better versus artificial intelligence. But to me, that's the near-term win with AI, right? Longer term, then I think we can get more into the diagnostics and sort of taking it a bit further, but we need to help the community with acceptance around AI. The second part, I think, of what's exciting near term to me is all of the movement around virtualization of care, because if we just keep coming back to this access issue, and bringing the care to the people, just like, Leon's doing with his, versus the people having to get to the care. I think that's where so much of the near-term opportunity is. And whether that's, telemedicine, I think there are whole new ways that we're starting to think about telemedicine, right? Versus sort of telemedicine, version 1 that had been inching along pre-COVID. But then a lot of asynchronous technologies excite me, because telemedicine at the end of the day is still a one-to-one, right? You have a clinician and a patient who are synchronous, and that from a resource point of view, you're not getting that leverage that I think we're going to see a lot more efficiency gain and leverage in the healthcare system as we move to more asynchronous modalities of data transmitting from patients and being interpreted in the cloud, and insights surface to clinicians, and you'll get a much more sort of one-to-many versus one-to-one relationship between providers and patients.
So I don't have a particular kind of technology that excites me for the purpose of improving equity broadly. I think it's really going to depend on the case and the specific inequity and the specific market that you're talking about. The cause of let's say an inequity in cancer screening rates in one market might be different than in a different market. The thing I'll say though about AI and machine learning and those kinds of technologies that there's a bit of a caution is to make sure that they don't embed structural racism in the United States society at large. That is a danger that's been sort of played out in the academic literature. There's a paper, I believe, in Nature or Science about 2 years ago, looking at risk stratification tools that didn't explicitly include race and ethnicity, and yet produced an inequitable result in terms of the risk scores they would assign to members of different communities for the purpose of flagging them for case management services. And this is because the training data comes from a racist society. So that's a challenge. And I think that means that you need to think about having some kind of governance structure in place, or an empirical verification step once you've built your tool, to make sure it doesn't produce that kind of an outcome.
And maybe, Mark, that might be a good segue into our next topic, which is really, once we acknowledge that there are disparities and inequalities within our healthcare system, we turn our attention quickly to how do we resolve that. And component to that is how do we know that we're making progress? How do we, first size up what the disparity is today? And then how do we see, down the line, are we actually making good on what our hopes were? So specifically, perhaps in your experience, how are those disparities measured? How do you measure improvement? And what role does technology play in identifying and in those disparities and measuring?
Mm-hmm. Yeah, it's a great question. Assuming measurement at the beginning, and we're actually imputing, meaning estimating using statistical techniques, the race and ethnicity of most of our members based on census data. We are able to watch over time for the effectiveness of our interventions. And whenever possible, if we really want to get a clear fix on those, we should randomize those interventions. That doesn't mean permanently randomizing you, withholding them permanently from some group. We want to do that for the smallest possible length of time. If we think there's a high likelihood they'll work, but we do want to still make sure they do work because we can be surprised. I would much rather know that there's an ineffective intervention that we deployed, even though we thought it was going to work, than to assume that all interventions worked and not really know, and risk the possibility that we scale up something that truly doesn't work very well at all. So my general approach to anytime we're either developing something internally or we're interfacing with a vendor who has an equity solution of some kind is to see if it can be randomized, at least in a step wedge fashion, so that we can get a reasonably good estimate on its effectiveness on overall performance and on the equity of services that our members receive. I think it's going to take a long time to get just facing all the societal barriers that we face to achieving perfect equity to get all the way there. But we can start making progress, I think, in the short term.
And Lucienne, I think that you brought up too, there's a few statistics relative to Georgia in specific. What other parameters do you look to really measure where are we at? How do I know that the world is getting better or getting worse? Where do you look to?
Yeah, I mean, again, right, it all comes to what's that baseline data. And in some of the areas, there is pretty good baseline data around disease prevalence and outcomes. Now, what's the validity of that underlying data and how are they getting the reporting around race and ethnicity? A lot of questions there. But, to the question of sort of how do you measure impact, I think one interesting debate that we've had as part of the HEAL coalition of, is there a role of regulation or government or certification or something here around digital health tools? And it's a loaded question because there have been some earlier attempts at this that have kind of failed miserably, at certifications. And, but, is there a way that we could require or at least offer the opportunity for technology companies to report in their data and for that data to somehow be validated or at least compiled in a central repository? Because maybe as a requirement, if it's a federally funded program or a state funded program, those entities could whether they require outcomes a priori that you have to demonstrate, or as Mark's saying, they just require that you measure it, right? And I think there's some, pretty good ideas and work to be done in that area where, contracting entities as part of your RFP or your RFI or your grant contract, to require that this kind of data be gathered and validated, and then to provide a mechanism for all of us to collectively share that data and learn from these experiences. Not everything's going to work, and that's okay, but we need to collectively learn and improve.
I think this is such an important point. If I could just respond briefly about this RFP question. So as I mentioned, we as a health plan interface with many vendors, constantly getting pitched. And in our RFP process, we inserted a couple of new questions that we are going to apply to all vendors who are member facing, especially, or clinician facing. So the two questions are, how are you measuring the equity of services that you provide and the equity of outcomes that you produce? And if you don't think this applies to you, tell us why. And the second question is, based on those measurements, what do you do to improve those equities, that equity of care and services over time? And say vendors who are building that into their business model already are going to have a huge leg up.
And Mark, maybe if we can stay there for just a moment, when you have these companies pitching you, these vendors coming to you, do they initiate the dialogue really with the cornerstone of inequity or disparity being, their reason or cause? or is that sort of a tangential or concomitant benefit to adopting the technology?
I think it really depends on the vendor. Some are leading with equity because that is one of their, if not their core business, one of their core business propositions. Others, I would say, this is the more common framing, is they're improving some aspect of performance, something about the quality and affordability of care. And like much of the healthcare industry, I'm not certainly not blaming them for having sort of recently come around to the importance of equity and getting more serious about it. They may have that sort of something that's more of an add-on. That doesn't mean they can't take it very seriously and do very well on equity, but it does take investment.
And that's actually, I think, a great segue to our next topic. For those in the audience, we are accepting questions if you want to put it in chat, and we'll try to feed a few over here. We've reserved a little bit of time at the end of our session today. I know that we have a number of entrepreneurs in our audience today. I know that that's a big part of the Health Tech Build community, and we're proud of that. So, one of the burning questions I know is, if I'm an entrepreneur in the space and I want to try to alleviate these disparities, where should I be focused? Where should I be pointing my nose? What should I, look to, as you said, Mark, create a business case, but also, of course, really cause so that we can mitigate these disparities and overcome some of these challenges. Maybe Leon, you can kick us off here as an entrepreneur in this space already. What challenges have you had, and what else do you see coming down the pike that you point your nose at?
So I'm biased towards AI, but there are some issues with AI. I mean, to the adoption of AI, depending on in which territory we sell worldwide. The threshold to get AI adopted in first world is much more difficult than getting AI adopted into developing countries. However, having said that, I do feel that artificial intelligence, or AI, or augmented intelligence, is machine learning technology, is here to stay, and it's kind of a future. It's the way we're going to see a lot of more technologies developing, because there is that impact, because it overcomes the necessity for specialists. It overcomes the necessity for certain trained physicians. It puts the technology into the hands of physicians, or into the hands of nurses or nurse practitioners, where you do have a lot more access to. It puts the technology into point of care. And I do agree with Lucienne, but that is very much a screening technology. But again, it all starts with good screening, because when you look at the difference between first world and developing world, is that first world has a proactive medicine, and a proactive medicine always starts with screening. You will look at in the United States, everyone's looking at hypertension, and you're treating hypertension before it becomes a disease, and that's where you do the screening. But when you look at third world countries, they're not looking to solve hypertension, they're just solving the disease, because they do not have any screening capabilities. They do not have the physicians in place. They do not have the infrastructure. So I do see a machine learning technology making a major impact, and again, it covers the whole gamut of every single type of territory, or every single type of market, from the developing to the first world markets. It's not a technology for the developing world. It's a technology which finds its position. You need to position it differently in every market, but it does have a major answer to a lot of the issues that we're dealing with here in this discussion.
Maybe we can open it up, Lucienne, Mark. If you were to put your entrepreneur hat on, where would you focus? What disparities? What type of company? Where would you go?
So I think, Mark brought up a good point earlier of you have to decide fundamentally, is your business around addressing disparities and social determinants of health and barriers to healthcare, or is your business maybe around some particular clinical use case, but you want to be sure that you bake that into your culture and your DNA. And just to speak to the second one for a minute, it was really eye-opening to me. A couple of years ago, I was out in Mountain View at a conference, And there was a talk to entrepreneurs about sort of where to start and focus your market. And it was, focus on the consumer, whether that's a provider or a patient in this case, who has high motivation and it's easy for them to access your, technology. So basically people who already have, technology at their disposal, good education, they're highly motivated, always start there, right? And build your success. And part of the problem, I think, is that often the, venture capital and, financing community wants to see that too, right? They want to see early, rapid growth and success. And there's this promise of if you do that, then you'll have the wherewithal to then move into those harder to reach communities. And I would argue that's fundamentally not true, right? Sort of trickle down healthcare technology really doesn't work. And so, if you start at the opposite of if I can build a great solution that's adopted by those people who have maybe low motivation because of education and competing interests in their life and a hard time accessing care, if I can do that successfully, I can easily grow that to the top right quadrant of people who are highly motivated and have access. So that was a real learning opportunity for me. And I've tried to take that to heart in our own company build for the common denominator of motivation, the common denominator of access, regardless of what problem you're trying to solve.
Yeah, I think those are fantastic points. I'll just add that unfortunately, inequities in healthcare are so pervasive in the United States that almost any sector that you're targeting is going to have them if you look. And that means you have an opportunity to make a real contribution to improving equity with your client base. And I think you should try to build for that. Even if that wasn't your original reason for getting into that area, it's something you can incorporate.
I want to, we had a question come in here, and I think it's an appropriate one. So we've seen tremendous investment into the personalized medicine sector, really coming at it from all angles. One of the challenges for a lot of these companies in personalized medicine are the associated costs of those treatments. So when we talk about disparities and in access to that, any thoughts on personalized medicine? Again, is this amplifying disparities while increasing care for a small population? Or Lucienne, to your point again, and would agree, does this really chalk it up to trickle down health care, which we really haven't seen happen before? Mark, Lucienne, Leon, feel free to chime in.
Oh, I think personalized medicine is for the the wealthy and the worried people at this stage. I think at this early stage, it definitely caters for a very small sector. However, if it can trickle down, and it can because of the high cost of personalized medicine, it at this stage is not going to trickle down. And I feel that it's only specifically designed for a certain sector. It's a profit type of technology right now. If you're an entrepreneur and that's what you're into, it does make sense, but it doesn't solve a major problem.
Yeah, to me, the chief barrier to this kind of technology is not so much the equity implications, to the extent those have even been investigated. It's more just the level of evidence. That's what we'd like to see first, is some really good evidence that this is better than standard, modern care for whatever the target condition is. Once you've established that, then we can talk further. And I'd especially be interested in the equity implications if those have been investigated.
Yeah, just to add to that, I mean, I think if you take one step backwards from personalized medicine, right, to the premise of like, what about if we could practice medicine, at the point of care, at the patient level, according to all the evidence and guidelines that are out there, right? And we could appropriately apply those to each patient and make that next best step in care. And maybe some simple things, right? Like applying, general, widely available genomic data, like, a huge percentage of the population, 25% maybe, doesn't respond to metformin, the first line therapy for diabetes. There's some really low hanging fruit of like, don't prescribe medicines that you can prove that individual's not going to respond to. And in the meantime, it's going to suffer consequences of poorly managed diabetes in that instance. So it's a bit to me like, like my comment on AI, like there's some near-term wins that I think are really demonstrable, that aren't quite there at full-on personalized medicine, and I think could be much more broadly applicable to the general population. And we should take those. And there's nothing wrong with personalized medicine, but there are a lot of other factors that have to come into play for that to be more equitable in its access.
Pulling up another question from the audience here, and this one's actually quite interesting. So there are certain procedures that everyone undergoes that are typically not reimbursed. And so, Leon, in the United States, that tends to be eye care and dental. You might get some reimbursements for that, but typically not too much. And as we look to other areas where you're going to have reimbursements that really is not covered, mental health is a big one. Interested in any technologies that you've seen, companies that you've seen in disparities regarding mental health care, psychiatry, and psychology. What are your thoughts and experiences there?
I guess I'm a little confused by the mental health aspect of this. Mental health parity is the law of the land almost throughout the United States. Not everywhere, but most of the United States is covered by those kinds of laws. And it's a covered benefit. We at Blue Cross of Massachusetts have dumped an enormous amount of resource into, well, better words, invested an enormous amount of resource in behavioral health over the past several years. And the main barrier we face is not one of reimbursement, but of workforce. That's the hardest thing about this. Trying to find a child psychiatrist is a real challenge. Trying to find any psychiatrist who can see you quickly can be enormously challenging. And that's where I think telemedicine can be a real game changer, because much of behavioral and mental health does not require in-person consultation in the same way that other parts of medicine do.
I would agree with that. And, I know over the past year, this has been a particular challenge building on existing challenges for universities, and college students and access to mental health. And there's been some really great adoption of telemedicine solutions for that because it's not just can you get an appointment, but timely, right? Can you get an appointment now if you are in crisis or feel that you need it? And I do think this brings back to Leon's, stating the obvious earlier, which I really appreciate, of this whole issue of access to, health insurance and the, and in this case, maybe the comment that the person asking the question is making is, so much of our health insurance coming through your employment and what kind of company you work for and what kind of job you do, right? And the implications of that really are dramatic. And so, if you work for a great Fortune 500 company, you likely have good vision and dental and mental health and an employee assistance program and telemedicine, and if we don't somehow figure out how to solve that access side, it's going to be really hard to make the impact we need to see on these, health disparities universally.
That's a great point. I think about the variation in benefits. That's something that needs to be looked at. I would say at a really high social level. That tends not to be solvable on a company by company basis.
We have a question now coming through, and this is really for the whole audience here. COVID is obviously on everyone's mind. I'm delighted to finally be back in the office. Second day back in the office in Boston, looking over a beautiful city. And hopefully, these good feelings and experiences I've had recently continue. But in your minds, how has COVID amplified, brought attention to, mitigated these healthcare disparities? And again, both looking at the United States and Leon, internationally, what your experience has been as well. Leon, maybe you can kick us off here.
Well, one thing about COVID is that we were introduced to this pandemic on almost an equal footing. I mean, it caught the whole world by surprise. And again, I don't want anyone to get angry with me. If you ever needed any proof that there's disparity in the US healthcare system, you have to go to the data. that shows that African Americans, Hispanics, and Native Americans, the statistics, the death rates were disproportionately much higher in COVID than the rest of the population. And again, it's again, you've got to look at it that we all came into this disease or this pandemic on an equal footing. And this is one of the most tangible proofs that there's disparity in the US health system. I can give an example in Israel. Israel, we COVID free because we have an HMO. We have universal healthcare, and I'm a proponent of universal healthcare. We have universal healthcare. And that's why the whole country was vaccinated in incredibly quick time. So we have no COVID in our country at all. But because of the system, it's systemic, because of the system in the United States, this is one of the greatest proofs that there's disparity in the US healthcare system. Just COVID brought that point home very, very, strongly.
Lucienne, any thoughts here on how COVID has impacted things?
I guess to, look on the, sort of looking forward, right? What have we learned? And I think, there's going to be, there's a decade at least of, papers that are kind of come out of the COVID experience from the scientific and public health and every other aspect. But, I do think there's a lot to learn in some of the efforts that have been taken to reach those underserved communities. And, the role of, community leaders getting vaccinated, speaking in churches, speaking in, other forums, building trust. And, they've basically had to take on some of these long-standing issues that drive a lot of the health disparities that we see: lack of trust in the healthcare system, lack of trust in the government, and lack of maybe education or understanding around some of these issues. That I at least remain hopeful that we'll learn from this. We'll look at the data, we'll look at what worked, and then we'll figure out how to apply that not just to the next public health emergency, but to our basic healthcare system and outside of infectious disease.
I agree that we're going to know more about this over the coming years. So it's far too early to say much, except the point Leon made, which is that the inequities in the United States healthcare system were just really highlighted by the inequitable burden of the virus itself. I don't even think we know yet about the associated off-target effects of the virus, such as the massive uptick in the need for behavioral health therapy.
Our next question comes again from the audience here. So when we talk about healthcare providers, most lay people think only about their physician, their clinician, whether it's their GP or their specialist, but that's who they focus on. Of course, we all know that healthcare providers span a whole continuum. Nurses, nurse practitioners, there's many more stakeholders here than just clinicians. Do you think there's an untapped population that could really be utilized and leveraged to help address some of these disparities? Mark, maybe we can go back to you on this one.
I think it's a great question, and the answer I think is yes. We should not be thinking only about physicians as healthcare providers. All the different professions you mentioned and others have a huge role to play. I think it's far better to think of people as complements and collaborators than substitutes and competitors.
Yeah, I think just to build on that, we have a physician shortage. We are building a worsening physician shortage in the US and globally. And I'm sure, this speaks in large part to the work Leon does to try to provide access where there aren't adequate healthcare providers. But, I'm a big fan of sort of the concept of top of license. And, how do we enable everybody on the healthcare team to practice at the top of their license, to impact patients to their maximal ability? That's the only way, one, that we're going to address the reality that we have an aging population with growing burden of chronic health conditions and fewer doctors to take care of them. But I also think in this area of health disparities, because of disparities of who becomes a doctor as well, right? They're often more faces that, patients identify with amongst other members of that healthcare team who, can build more trust or may have different shared experiences with the patients. And so I think it's really interesting to work through that of how do we leverage every member of the team, their education, their experience, their history of what they bring to their job, and how they may be uniquely suited within the healthcare delivery team. But I would encourage the entrepreneurs, know those people too, right? Spend time with nurses, spend time with pharmacists, spend time with front desk people and medical assistants, because they'll have a lot of insights for you about the patients that the doctors are too busy to necessarily be able to gain.
Just to add to that point, I think to the entrepreneurs in the audience, I think we should definitely look at point of care. We should definitely look at developing technologies that nurse practitioners can utilize at point of care, because it's unsustainable. What we have and the shortage that we have of physicians around the world, it's really unsustainable. We need to move the nurse practitioners. These people, we need to move them forward. The only way to move them forward is there's only two ways. One is education, and there's a limit to how much education you're going to put in, because how much are you going to get back from it? But the other way is to put technology at point of care in their hands to reduce the burden on the physician. And I think if there's entrepreneurs, this is another place you should really look at.
We have just a few minutes left, and one last question here. So it was just a few years ago that CMS unbundled remote patient monitoring codes, which many people are saying, has really opened up a whole new industry here in the United States. There's been tremendous investment in the sector. One of the things that a lot of these companies try to address is we are going to help try to level the playing field here. And so an extension of screening a patient is monitoring the patient. Any thoughts on how these RPM codes are being used, and whether that you are actually seeing them help to dispel some of these disparities and inequalities?
I'm happy to chime in because I spend a lot of time in this space. And I think what I often start with is, RPM is a means to an end. It's not the end, right? And the end is better healthcare for those patients, right? More proactive management of chronic health conditions, or post-acute, a post-acute type situation where you're trying to prevent another, outcome from happening. You're trying to, monitor weight gain and heart failure to prevent or catch early an exacerbation that may result in a hospitalization, or you're trying to monitor, high blood pressure to prevent that acute, need for care or event. And so absolutely that can help, with the disparities, with the access to care issue. But I just think folks need to keep in mind sort of why we're doing it, both from the company point of view, from the clinician point of view, and what patient need we're meeting, and not get too caught up in the transactional nature of now there are billing codes for this thing, so I should go do this thing.
I couldn't agree more with you, because I think the secret is proactive care. I think the secret is proactive care, but put it at point of care. Bring it much earlier to that. Put it in the hands of nurses, nurse practitioner. Proactive care. Patient monitoring is at a stage where it's a bit late. But proactive care will make a major change and change healthcare for all of us.
I don't have too much to add, except to say I agree completely with Lucien's point that that the monitoring itself is not the end. And value-based payment models, ACO type payment models, other kinds of TME risk models, total medical expense risk models will help, I think, provider organizations decide which remote monitoring technologies they want to invest in and try out.
And I think, Mark, you've brought us to the end of our session. I want to thank our fantastic panelists, Mark, Lucien, Leon. Thank you for taking time out of your busy schedules to join us today. I want to thank Jen Sato for introducing us and bringing us all together here as well. Jared McLean, who's helped on the back end of the technology. Appreciate your help. And of course, our sponsor, MediCuity, for helping to bring all of this together. We look forward to seeing the Health Tech Build community again soon. And thank you, everyone, again for your time. Take care.